Okay, so our group evaluated the correlation between income and access to healthcare in Santa Barbara County. Together were Yusuf, Alec, and Taylor. So generally speaking, citizens of wealthier nations typically have access to better healthcare than nations with more impoverished situations. However, beyond the national scale, there is significant discrepancy within subgroups of the population, and that's definitely influenced by economic status. So according to an article in the American Journal of Surgery, healthcare access outcomes remain inequitable for minorities among individuals who speak another language or economically impoverished, which is what we're considering today. So in our study, Santa Barbara County is going to be examined, and we'll see the correlation between income and access to healthcare. We're going to specifically look at 2 areas near Cottage Health facilities. And ideally, we'd be able to explore this question and see the implications for solving health access inequalities locally, but also taking a look at the issue and adding more information to the idea globally. So our motivation for this was just to see what could be done with this information and how we could better improve our situation here in the county. Before we did any analysis, we predicted that areas with lower income would self-report lower health, as well as lower prevalence of health insurance and primary care providers. So we expected that lower household incomes would not have enough money to pay for care, and that would be the issue. And we're also considering that lower income households typically have lower quality food with less nutrition, and also their lifestyles would put them at risk for medical conditions that would need professional medical intervention. And also we wanted to look at the systemic problems with healthcare leading to poverty and just the cycle repeating where you don't have enough money to pay for healthcare, you don't have the ability to go to work because of poor health, and it just declines and declines over time. So ideally, through this study, we'd be able to find the correlations between them and reduce that issue here. So what's our motivation? Our motivation is a healthier Santa Barbara County. So the 2 variables we looked at were median household income and health outcomes. And then with health outcomes, that was specifically insurance coverage and primary care provider. We thought that would be a good representation of the variables in our area. And then the 2 locations we chose were census tracts that contained cottage facilities, as well as those adjacent to cottage facility census tracts. And that was just because we wanted to make sure that distance from the actual health care facility wasn't impacting our findings on this.
So the first indicator that we looked at was household income, and we compared between the tracts in Goleta and Santa Barbara, and we also took the data to compare the 2 areas together. So firstly, we would expect that in Goleta, tract 29.14 and in Santa Barbara, tract 13.04 would have the greatest healthcare access as they had the highest incomes. Conversely, we would expect that tract 30.07 in Goleta and 11.01 in Santa Barbara would have the worst healthcare access as they had the lowest incomes. So these residents in these areas have to neglect their health as a trade-off for affording other basic needs such as food and rent. When we compared the median household incomes between the 2 areas, they looked very similar. So there wasn't really much difference, but then we used further statistical analysis. We've created a box plot to demonstrate the differences. And as you can see, there's much greater interquartile and upper quartile values for Goleta. So this indicates that we expect to see a greater range of healthcare access here compared to Santa Barbara. The first health indicator we looked at was the primary care provider. So interestingly, in both areas, we found that the middle income earners had the highest percentage of people with a primary care provider. So in Goleta, tracts 30.04 and 29.22 performed the best. In Santa Barbara, there were actually 3 tracts that performed the best. So 3.01, 3.02, and 5.02. All 5 of these tracts are reported having 81.5% to 100% of the population with access to a primary care provider. In both Santa Barbara and Goleta, the highest income earning tracts underperformed to our expectations. So we would expect them to actually have the greatest access to a primary care provider, but instead they performed sort of mediocre compared to what we thought they would perform at. Additionally, inequality levels when it came to primary care providers were higher in Santa Barbara than in Goleta, as shown in the bar chart. So there's sort of polarization on each end with high access to a provider, but there's also a high number of people who don't have access to a primary care provider. Goleta, on the other hand, was more consistent with its results, and it was sort of still on the high end. So you still had a lot of its population with a primary care provider in each tract. So from this data, we can sort of conclude that Goleta did slightly outperform Santa Barbara overall, despite the fact that Santa Barbara had 3 tracts with 81.5 to 100% of its population with a primary care provider. However, the difference wasn't that large, which made us consider that other factors outside of income affected population's access to care. We also looked at health insurance as another indicator. So we expect to see that higher income areas have a larger percentage of the population on private and employer healthcare. We also justified that having areas with high public health insurance was sort of a negative, as they would usually be able to afford private or employer health insurance, and then public sort of just the basic requirement. When we first compared the tracks, the low income areas performed the worst. So track 3.01 in Goleta had the worst rates of public, private, multiple, and no health insurers. It was only track 30.07 which had the lowest rate of employer insurance. In Santa Barbara, track 11.01 performed the worst across the board, so having the lowest rates in all aspects of health insurance. Both of these areas had almost identical income levels, around $42,000. Sorry. When we compared the insurance coverage between Santa Barbara and Goleta, Goleta did do better overall. So it had higher rates of employer and multiple health insurers and lower rates of public and no health insurers. We did use Cottage data to go connections tool to test whether there was any statistical significance between the two values. We got back an R value rating of 0.3, which is sort of moderate. It sort of means that there wasn't much significance between the two values, but we sort of disagreed with that with our findings, so we decided to look into some more academic sources. We found that there were multiple sources that described that there was in fact a relationship between health insurance and income levels. So, for example, there was a study by Alvarez and El Said, which used a standardized world income inequality database and the World Health Survey to examine the impacts of health, insurance, and income, and the data revealed that higher income areas had better access to healthcare, as well as greater inequality, leading to prevalence of ineffective insurance. And this is just one example from a multiple list that we outlined in our story map. And we also concluded that better health insurance also had a cyclical effect, so boosting income further, as employers would be able to go to work more often, take less sick days off, and overall lead to a boost in productivity.
Adding on to this discussion of the Alvarez and El Said study, our research displayed residents with higher income are more likely to be privately insured, while those with low income are more likely to be publicly insured. This is often due to whether their employer offers healthcare or not, and it could be used to examine healthcare efficiency between private and public insurers in more developed countries where some sort of healthcare is usually made readily available. Negative feedback loop associated with poverty and health. In 2018 study, Bohan and his colleagues found that socioeconomic and healthcare access disparities contribute significantly to neonatal mortality and healthcare resource utilization. Furthermore, they found that in the US, preterm birth complications account for about 2/3 of all deaths and is markedly higher among underprivileged women. These events are correlated with low socioeconomic status and diminished access to healthcare. These findings illustrate how those in lower income groups specifically suffer at an increased rate due to their lack of access to healthcare. Proneness to child mortality is just one of those many difficulties low income families face, with an amplified effect due to reduced access to or ability to pay for healthcare. Low-income families in Santa Barbara and the world typically live in close proximity to one another relative to those with higher incomes. In addition, inexpensive food in the form of both fast food and corporate grocery stores is made easily accessible to these low-income housing facilities, contributing to lower overall health standards. These factors increase the likelihood of developing and spreading sickness in these communities, influencing the need for healthcare, increasing for lower-income families compared to their wealthier counterparts. Suggestions for cottage population health. Including real number statistics could be interesting, and you could find those calculated based off the given percentages and population in the area. And specifically for the health tab, if you hover over the bar, it shows the percentage of individuals that fit the demographic. And I think it would be interesting if you hovered over the left side of the bar, if it showed that percentage, and if you hover over the right side, it showed the rounded statistics. And I think this would be interesting because during the pandemic, it became apparent that people are really interested in statistics due to like COVID counters and all those things that became popular. And I think it would lead people to spend more time on the site and recommend it to other people. Adding to the connections page, more variables to compare with each other could just lead to more correlations and examination. And then middle school presentations and high school would be a good idea to spread geography knowledge to the youth and get people aware of the site, and they can bring it back to their families. Future work and limitations. Outdated data is impactful due to the COVID-19 pandemic. The effects COVID-19 had on income and healthcare would drastically affect this data. Scope of census tracts. Expanding upon the amount of census tracts studied would provide further comparison and potential correlation. As far as the reliability of the dataset due to respondent biases, individuals with binge drinking habits and cancer often report their health as excellent, good, or very good, even though their health isn't, and self-reported questions may lead to inconsistencies in data regarding health, as people tend to bias towards thinking they're healthy. And then lastly, if we just expanded the study to examine more cities and census tracts in the world and take into account more variables, I think we would definitely find correlation, as it's an apparent issue, as we found through our empirical study research. Thank you very much.